So, good evening, Prof. Prof, we are ready. We can start with the webinar. Prof. Hari, we can start.
Okay, sorry. Okay, a very good day to everyone. It's a pleasure to be here, basically, and this is the webinar series from the World Union of Wound Societies, and it is the largest society, basically, in the world with wound care specialists, doctors, nurses, paramedics, and everyone world over. Now, today's session is basically looking at beyond the blade, the power of therapeutic cleansing and continuous integral debridement. That's the first topic of today's session. Firstly, in our webinar series, we actually propagate how to learn, engage, and elevate. And I would like to thank Ergo Medical for actually members, basically all over the world. Now, one of the things that the Education Committee of the World Union of Societies, what do you call that, is proud about is its education initiatives. And with us today, we have basically two very prominent speakers, very close friends also. We work together basically with the Wound Infection Institute, the International Wound Infection Institute, and quite a number of these consensus documents have been published and for the usage of all the members. So the first speaker, basically, we have got Professor Caroline Carville. Now, what do you call this? Caroline is actually a very, very senior professor of primary health, and she's also has got a vast experience in looking at wounds and also with silver chain nursing before this. And at the same time, basically, uh, she works with 13 University, and her work bridges clinical practice and academia, focusing on translating research into practical strategies that improve patient outcomes in community and home-based care settings. Internationally, she's recognized for leadership in wound assessment, infection prevention, and skin integrity. She's authored about more than about 150 peer-reviewed publications and textbooks, contributing significantly to evidence-based wound care worldwide. So when we start, basically, she will be actually presenting on what do you call this, the first topic, as I mentioned. But before that, can we have the poll? Prof, can I have the poll up?
Yes, Prof.
Prof, do you have the poll up now?
Yes, my colleague Ahana is there. She's doing it.
Okay.
We have
Sorry,
the
Caroline.
poll up.
All right.
Yes.
Somehow I still see the what do you call this? The agenda up there, not the poll itself. Caroline and Dot, do you all see the poll?
The poll is up, but I think you need have to explain to people what to do.
Yeah,
because there's only one
screen, I don't see the
response.
poll.
Would you like me to relaunch it? I can see 9 responses from my end.
Okay. Just the
We can't see anything
see-
on our end, so maybe we can relaunch the poll again.
that's
Sure,
what I
let
was
me
saying, because I
relaunch it.
can't see the Do you all still see the poll?
No, we can see the poll, but there's nothing recorded.
Hello, for those that are on your phones, please open your chat function. The poll is over there. You can submit your answers via the chat function.
Oh, you put it in the chat. Okay. All right. Okay, sorry. I usually, just to go and add, normally when you put the polls, we usually don't put it in the chat. We basically put it up in the screen itself. Never mind, no problem. What does therapeutic cleansing mean to you? So in this sense, basically, they are actually looking at more of multiple answers of that. So there's no choice per se. So please just put in this just for us to know whether what is your response in terms of therapeutic wound cleansing. Now, this is very important. I think when Caroline, myself, I think Dot, all of us were there in London, basically. One of the things that we looked at was we coined that term of therapeutic wound cleansing. So we're going to find out what does it mean to you as wound care professionals. Okay, we have some multiple answers. The first, opportunity to change the trajectory of healing. Another one is from Sandra, where the first opportunity to change the trajectory of healing. Oh, same thing. Okay. I think what we'll do is with attention to time, I think we shall proceed with the first lecture by Caroline first, looking at Beyond the Blade, the Power of Therapeutic Cleansing. All right. So where we look at a new era in wound and skin cleansing guideline-driven practice, basically new key concepts and recommendations on wound and skin cleansing and considerations for selecting wound and skin cleansing solutions. Caroline, I think, very sorry when we actually continue with the poll, maybe what do you call this? You can start your presentation now. Thank you. You have the floor.
Okay. Thank you, Professor Harry. It is appreciated. And thank you very much indeed. It is really my privilege to be able to present to you tonight the new era in wound and skin cleansing that is guideline-driven practice. So thank you. So what is wound cleansing? I think wound cleansing means different things to different people, as we've just seen some examples when we've been asked about therapeutic wound cleansing. But wound cleansing is a significant component in preventing and managing wound infection and preventing a wound, or rather preparing a wound for healing, rather than the ritualistic practice that many of us have been taught over past years, and particularly the practice of anointment, as we call it. So the management of acute wounds may be very appropriate to treat the wound or clean the wound very gently in a form of an ointment, but in the chronic wound, we need a different approach. Historically, we learn a lot about wound cleansing. This is Hygeia. Hygeia is the mythical offspring of Asclepius. Asclepius was the Greek god of healing, and his other offspring was named Panacea. But it was the Minoans of Crete that invented soap. And with the beginning of soap, that was seen to be a social obligation for personal hygiene, as well as the way we managed wounds. And so the concept of cleansing throughout the ages has been one often misinterpreted. The early Egyptians, 3,000 years or so BC, we learn from that wonderful document, the Papyrus Ebers, that they washed their wounds with milk and water. Now, that would seem very appropriate, at least the water would today. We know milk contains cytokines, but it was considered more therapeutic if the water had been used to bathe the male head of the family first. So they used the bath water. There's also records that they used beer, and beer, like today, would have been effervescent to clean their wounds. Hippocrates, who was born in 460 BC on the island of Kos, which is a bit of a short swim off the Turkish coast, left behind in his legacy of writings that it would be appropriate to use wine and to keep the wound moist, but not to irrigate a joint. And that today would still be considered good practice. Now, Galen was the physician to the Emperor Marcus Aurelius. And at the turn of the 1st century, he documented the fact that wounds needed to be purulent in order to heal. So he was accredited with what is known as the laudable pus theory. So one assumes that if the wound had to be kept purulent, that there was very little cleaning to be done at all. Paracelsus was a barbershop surgeon in the Middle Ages, and he was the person who described exudate as nature's balsam. But he also documented that wounds should be kept clean and covered quickly. But it was Lord Lister, Joseph Lister, in 1867 who launched the antiseptic era. And at this time, up until this period, many died from wound infections. And really, it was just before this turn of 1860 where we had Pasteur's discovery of bacteria. And so they then began to understand about wound infection. And Lister proclaimed that the wound needed to be cleaned very well. He introduced carbolic acid and carbolic acid soaked dressings. They sprayed the operating theatre with it. They washed their hands in it, which is one of the reasons doctors went into gloves, because they all ended up with dermatitis. They soaked dressings in it, and as a result of using carbolic acid, they reduced the death rate post-infection and their amputation rate down to 15% from nearly 46%. However, the impact of carbolic acid on healing fibroblasts would have been extremely toxic. So at the turn of the 1900s, there were a lot of very entrenched rituals. It was thought that if they washed leg ulcers in hot water, then cold water, then hot water, then cold water, that they would aid venous return. But even if you think about the logistics of that, that would have only worked if they turned the patient upside down. But I love these old pictures that come from a nursing text dated 1917. The use of a sitz bath or salt added to warm water was something that was used not just for perianal wounds, but also for comfort. But if you look at these pictures on the left, surely this would have been an OC health and safety risk. And I would suggest very, very little therapeutic value. So in between, over the last 30 years or so, there have been a lot of studies, very low quality, that have actually looked at the whole principle of cleaning wounds. In 1980, we had Cruz and Ford, who actually did a study to determine whether or not there was an increased risk of infection if nurses didn't wear gloves. In 1987, we had Sue Tomlinson, who did a study in the UK where she compared infection rates when nurses cleaned the wounds with forceps versus clean, intact hands versus gloves. And she, like Cruz and Ford, found no increased risk of infection. In 1989, Kelso took up the challenge to examine the myth that Is there a difference between the clean and dirty forceps? And she too found no difference or no increase in infection. And then in 1995, Ellen Barr looked at the principle of when we should begin to clean the wound. Do we clean the surrounding skin first, or do we clean the wound first, or vice versa? Prior to 1995 and Ellen Barr's work, the principle was to clean the outside of the wound first, then the wound. But she was able to demonstrate that the wound is more vulnerable, so it was considered better practice to clean the wound first, then the surrounding skin. But here we are at a time, and it's taken all these years to actually bring together evidence to look at how we really should be cleaning wounds. And the International Wound Infection Institute, building on the work that they did with their wound continuum, their infection continuum, pulled together and did the research. And it's the research that I'm going to present to you tonight. So the methodology, first and foremost, the group developed their clinical questions, then a systematic review of the literature using MESH and EBSCO terms, searched major databases. There were review of websites, guidelines, and soft literature. The evidence was screened and ranked using the Joanna Briggs Institute levels of evidence, which are presented to you in this diagram on the right. So level 1 evidence is experimental, down to level 5, which is really expert opinion. And then we conducted a consensus process using a modified Delphi process, which used the RAND and the UCLA appropriateness method, which is very much validated. And so the outcome of this project was the evidence that's presented in the document. So why do we clean a wound? Some would argue that modern dressings in their own right will absorb exudate, and with that, microorganisms in the wound, and maybe there's no need to clean a wound. However, the consensus really talked about the need to reduce the bacterial load in the wound or the organisms in the wound, whether they be planktonic or whether they be biofilm encased. It's necessary at times to remove necrotic tissue or wound debris or excessive exudate. It certainly may be necessary to remove malodor. And if you have a lot of contaminants on your wound, it's very difficult to assess the wound. So a clean wound facilitates good assessment. And certainly prior to taking a specimen, either for wound culture or biopsy, we need to aseptically clean the wound first using an inert substance such as saline or sterile water. So in the evidence in the guideline, we looked at the different methods of wound cleansing. Perhaps the most common method is wound swabbing. That's usually using forceps or gloves, whether they be sterile or unsterile, and usually gauze, wet gauze to clean the wound. Scrubbing relates to the use of cleansing pads, and this is a form really of mechanical debridement, vigorous mechanical technique to clean the wound or scrub the wound to remove eschar, slough, or other debris. We could irrigate or flush the wound, and the recommended pressures for that are 8 to 15 pounds per square inch, and I'll explain that a little bit more in a moment. Or we could use soaks or wet packing. These are moistened cloths, usually gauze, that rinse the wound without friction. So layers of gauze are usually dampened, laid on the wound, and then removed. A compress, on the other hand, is damp gauze, not wet gauze, but damp gauze. And the damp gauze facilitates a fluid shift from the wound to the gauze. We have negative pressure wound therapy installation, so dwell and the suction. And there are some what we refer to as hydro-responsive dressings. These are comprised of absorbent materials and usually saturated with Ringer's solution. So the antiseptic non-touch technique group or framework has a prescriptive method of cleaning a wound. Their standard aseptic technique is used when the wound healing environment is not compromised or the client, patient, or resident is not compromised, and the criteria doesn't require a surgical aseptic technique. So standard aseptic technique involves the use of non-sterile gloves, sterile equipment, and sterile solutions and sterile dressings. And it's performed when the procedure is anticipated to be less than 20 minutes or doesn't enter a sterile cavity. Surgical aseptic technique, on the other hand, is implemented when the procedure is more complex, when the wound may enter a sterile cavity or a CV line. It could be an extensive wound or one where it's anticipated to take longer than 20 minutes of wound exposure. And this requires insertion, or if it requires insertion of a dressing material or device into a cavity. So with surgical aseptic technique, it's sterile gloves, sterile solutions, sterile dressings, sterile equipment. This is how we teach our students, and the standard ANT practice identifies key parts that can touch each other. So the tips of the forceps can touch each other. The gallipot, the gauzes, the solution, and the dressing towel that may be put down, and of course the new dressing. So trying to teach students what can be touched and what cannot be touched. When it comes to irrigation or flushing, I've already mentioned that it's usually 8 to 15 pounds per square inch that's recommended, and various studies have highlighted the significance of this for flushing or cleaning the wound without causing microorganisms to be embedded further into the wound. And so these pressures can be obtained either using a 35C to a 20cc syringe with a 18 to a 22 gauge needle. Now, there is some evidence, and has long been some evidence, for showering or washing wounds as long as the water is potable, that is, as long as the water is drinkable. And ideally, the tap needs to be run for about 3 to 5 minutes in order to flush the pipe and the edge of the forcep on the tap. So the evidence is there that showering or washing well-approximated incisions or chronic wounds is performed after a risk assessment in a consistent manner with best available evidence and within policies and procedures of the service provider. The recommendation in the consensus states that we need to assess the individual, their wound, and their healing environment to determine whether or not it's appropriate to shower or wash the wound. So, as I mentioned, this evidence has been around for a while. Back in 1989, Krintz and his colleagues actually conducted a study that showed no increased evidence of infection when you showered well-approximated wounds without open drains within 1 day post-op. In 1992, Angaras found tap water had no increased risk of infection in a cohort of 617 patients, but she found it necessary to run the tap for 10 to 15 seconds to clear the tap. In 1994, in Birmingham, Carol Dealey did a study and found no increased risk of infection when tap water was used. And in 1997, we had Vanessa Jones and Sue Bale do a similar study with no increased evidence of infection when it was performed in Cardiff in Wales. So we heard already the concept of therapeutic wound cleansing, and I really like this term. It relates very much to the active removal of surface contaminants, loose debris, non-attached, non-viable tissue, microorganisms, and remnants of previous dressings from the wound bed and the peri-wound space. And as our next speaker, Dr. Weir, is so often stated as saying, we need to clean it like we mean it. So the acute wound that's going through a very orderly, timely repair process, you can treat gently and clean very carefully. However, the chronic wound needs to be really cleaned like we mean it. So the recommendations from the consensus document in regard to cleaning is that therapeutic cleansing of all wounds when the wound dressing is changed or removed. This is only a level 3 evidence because there have been very few studies around the frequency of wound cleansing. Therapeutic cleansing of the wound bed, the wound edge, and the peri-wound skin with an inert wound cleanser before collecting a wound or tissue sample for culture or histopathology is required. And again, level 3 evidence. And it's required that we implement universal precautions when conducting a wound cleansing procedure, and that's level 1 evidence. So within this document, I love this document, how it presents the fact that we have divided the wound and the peri-wound and the surrounding skin into 3 zones. The wound is obvious, it's to the edge of the wound. The peri-wound is 4 centimeters surrounding that wound, and the surrounding skin is considered up to 20 centimeters surrounding the wound. Except wounds on the lower limb, usually we would consider the surrounding skin from joint to joint. So regardless, therapeutic wound cleansing, considering the wound, the peri-wound, and the surrounding skin. We can understand why we clean the wound. We need to be able to inspect it. We need to be able to assess it. We need to make sure we've removed excessive contaminants and debris, of course. But when it comes to the peri-wound, this is really equally as important. And this just happens to be a wound that I'm using a molecular light fluorescent camera. And so if you look at this perianal wound at the top on the left, you know, there is some changes in the granulation tissue. It's dark red, it's a little bit jellyish, but there's nothing of evidence in the surrounding skin that would make us generally concerned until we fluoresce this with a molecular light camera. And so when it shows up bright red like this, it demonstrates the significant load of Staph aureus that's in the surrounding skin. So the organisms in the wound are on the surrounding skin, the peri-wound skin rather, and possibly the surrounding skin. And the organisms on the peri-wound skin are in the wound. So it is important to clean the peri-wound. The recommendation for cleaning the surrounding skin is that we need to therapeutically clean the skin using a mild skin cleanser with a pH ideally slightly acidic or neutral effect. And we need to be able to clean this skin very well. And if you look at these images here where we have significant scale or maceration or macerated scale, ideally, I would clean these with a debridement pad or a wad of wet gauze, but you need to really clean this off and then moisturize it. So in the document, we have this lovely algorithm that lays out the steps for performing a wound procedure. Ideally, we're going to use basic universal precautions. We're going to select the wound dressing procedure technique. Again, is it a standard aseptic technique or is it requiring a surgical aseptic technique, or potentially is it a clean technique where we're going to shower or wash? We're going to select the wound dressing procedure equipment. We're going to perform an aseptic or surgically or standard technique, and we are going to then complete the procedure. We're going to document the outcome and, of course, perform standard hand hygiene and disposal of the used equipment and dirty dressings. So when it comes to solution considerations, within the document, it talks about the need to consider the type of wound procedure and therapeutic cleansing technique, to consider the characteristics of the wound bed, and in particular, the depth of the wound. The increased risk or presence of infection needs to be considered, as does the pH of the solution. The solution's cytotoxicity and allergenicity is important, and I would suggest that somewhere in the world, someone will be allergic to everything that we use, and our goals of care. And of course, we need to always be mindful of our organizational policies and resources available. So the difference between isotonic versus hypertonic inert cleansers, isotonic saline solutions have the same concentration of sodium chloride as cellular body fluids at 0.9%. Sterile water is hypertonic with an osmolarity of 0. And the concern about irrigating very deep or extensive cavities with large amounts of sterile water is that it can result in hyponatremia, hypoosmolarity, and fluid overload, which is usually why saline at 0.9% is used when an inert cleanser is required. The traditional antiseptics that have been around really for well over 100 years have initially done the job. But when we think about it, the hypochlorite solutions, they had their genesis in the First World War. And you have to remember that in the First World War in Europe, when men were drowning in the mud in France, infection was rife. They had no antibiotics at that era. They had no blood transfusions. And it was left to people like Dakin and Lorraine Smith to come up with a solution that would help save life and limb. So all of these products here, we know have possibly passed their use by date. They still have relevance to people in low resource countries, but they do come with some risks, either to healing toxicity or other cell toxicity. And in the case of peroxide, the release of oxygen can lead to emboli that can lead to increased mortality. So during the 1980s, there was this group of scientists and clinicians who did some extensive research onto these traditional antiseptics and found that they were quite harmful to tissues. So what changed the goal here was occurred in 2014 when the Centre for Disease Control in Atlanta, Georgia, and the World Health Organization in the same year put out an urgent call for antibiotic stewardship within medicine, livestock, and agriculture, because at that time there had been no new families of antibiotics for 20 years. And may I say, we're still sitting in that same era of concern. So scientists went back to the bench and they looked at how they could reduce toxicity in some of the products, such as iodine, polyhexamethylene biguanide, gentian violet and tea tree oil, and of course the hypochlorous acid solutions. And the goal was to make these more tissue friendly and to reduce cytotoxicity. Now, if we are cleansing patients in a shower or washing them, we need to be mindful that soap is really not ideal for in a wound. It is highly alkaline. It's comprised of lye. Lye is a metal hydroxide. It's obtained from leaching of wood. And it is extremely, as I mentioned, highly alkaline, which is not ideal for a healing wound. So if people are showering and getting soap in their wound, then they need to rinse it extremely well, or ideally use a pH neutral cleanser. So within this document, there is rather an extensive table on commonly used skin cleansing solutions, both antiseptic and inert. And in this table, it outlines very much its pH, its therapeutic index, and its safety profile for all of these solutions. So bringing this all together, the recommendation is a level 1 evidence that we should use a wound cleansing solution with antimicrobial properties as part of a comprehensive wound infection and management plan when wound infection is confirmed or suspected. So in the document, there is a lovely algorithm how you might make those decisions. And as you can see, it's a step-by-step process. But that can be summarized by the fact that you want a solution that is going to be antimicrobial. If it is to be antimicrobial, that it will be sufficiently efficacious for those organisms within and without a biofilm, and it will do no harm. So if you would like to access this document, if you haven't already, you could use the QR code, or you could go onto the International Wound Infection Institute site. So I would like to thank you very much for listening, and these are my references. Thank you.
Thank you very much, Caroline. I think we'll keep questions for the next session itself. I think we proceed basically to the next polling question.
We have the poll launched. If someone is not able to see the pop-up, it is available in the chat as well.
Okay, the polling question now basically is, what are some properties of an ideal wound cleanser? So it is a multiple choice question. So in terms of good efficiency, safe for key healing cells, ideal skin pH of 5.5, and aids in debridement. You can start submitting your vote. Thank you. Okay, we have 33 responses. Okay, so ideal skin pH is 35.5, we have 32%. Safe for key healing cells. I think this is important, basically looking at the normal extracellular matrix and the fibroblasts. In terms of good efficacy, say basically 22%, and AIDS in debridement, 18%. All right. Okay, I think we can put in the next poll. Four or five of them have problems submitting. All right. Okay, the next one is, how familiar are you with the concept of integral debridement? This is the best of one, basically, one choice. Not familiar, no, but not familiar, or very familiar. Okay, I think we have at least half of them, or 47%, who are not very familiar with it, and 23% who are very familiar. So I think this brings us to the next session, where we have the wonderful and what do you call this special lady from the US, Weir, who will actually wow you with the next section itself. She's actually a highly respected wound care clinician educator from the United States, with decades of experience in wound ostomy and contrast nursing. And incidentally, I have to mention this, she's married to a wound doctor also. All right. She has dedicated her career for advancing evidence-based practice, clinical education, and improved patient outcomes in complex wound management. She's also the co-chair of the Symposium on Advanced Wound Care, or the SAWC, basically. And she helped to shape one of the world's leading wound care conferences, which is the SAWC, and which is usually linked with the Wound Healing Society of the US also. And it's held basically twice a year, in spring and also what do you call that, the fall in Los Angeles. Las Vegas. The fall one is always there. She's also a faculty member of the Wound Certification Prep course, supporting clinicians in achieving professional certification. Internationally, Dot contributes as a committee member of the IWII and supports the development of quite a number of global consensus documents and best practices in wound infection prevention and management. So with that, over to you, Dot. You have the floor. And most of them are not very familiar, so we are going to learn from you. Thank you. You have the floor. Take care.
Thank you. There we go. Hopefully you can see my slides. So thank you, Professor Hart. Can you see the slides?
Yeah, can.
Okay, all right. Thank you for the introduction, and I add my welcome and my good morning. It's morning here in the United States, for me anyway. So I'm very happy to continue on from with what Keryln was talking about with wound cleansing, because in my view, anything, I usually can ask this to an audience, but if you look at that picture, do you know what that picture is? And it's a power washer, which of course we don't use on open wounds. But to me, cleansing anything can be rewarding. And this is me using a power washer because I just like to see things go from dirty looking to cleaner. And wounds are no exception. You know what? Because we can visibly see when we've gotten a wound cleaner. But it can become very ritualistic and not therapeutic. And as Keryln mentioned, we, for years, were just anointing wounds where we would dribble a little bit of saline on there, pat it dry, and then call it a day. And so we now know that we need to be much more intensive in our cleansing of wounds because let's face it, wounds can be a buffet for bacteria. And especially those that have devitalized tissue, we're going to have a breeding ground for the bacteria to sit there. So it's important that we not only get the wound clean, but we also get rid of the slough or the necrotic material that's in the wound. So Keryln already showed you some pictures like this, but we want to, she emphasized the peri-wound, the 4 centimeters out from the wound edge. And there was no real science behind this. It was mostly expert opinion, but it's expert opinion based on a lot of what we have seen in the past. So we want to look at that peri-wound skin. And if you look at this, it looks a little macerated, but I'm sure you've seen this before where it's just sort of hyperhydrated skin cells that you can almost nudge away with a piece of gauze. When I fluoresce that, look at the bacteria. This is again what Keryln showed, that there's a lot of bacteria sitting in that peri-wound. There's also bacteria in the wound itself, but because collagen and tissues fluoresce dark, sometimes it's a little harder to see. But we don't want that contaminating over onto the surface of the wound. So after I soaked it with the hypochlorous acid, pure hypochlorous acid, which in US we use WUWHS, we soaked it for 15 minutes, then cleansed it, and you can see it's very easy to get that off, but we have to address it and we have to be mindful of the need to do so. This is another example. We were showing you gram-positive, gram-negatives with the red fluorescence. When you see this cyan or hot white color, that's Pseudomonas specifically. And Pseudomonas is a common contaminant, but after a soak with WUWHS and after a good cleansing, you see we are able to address that and get it off. So again, emphasizing the importance of good wound cleansing. There we go. So this is, again, maceration holds on to bacteria when you fluoresce that. Now I'm going to play this video real quick. This person did not have a lot of pain, but there's 2 points I want to make here. One is I'm cleaning it with pure hypochlorous acid. I'm able to scrub him, and actually it felt good to him because this was pretty itchy. What I want you to notice is my gauze. See how the bacteria is just in that gauze threads? You want to put your gauze down frequently and get a fresh one because you will be then cross-contaminating. So make sure that you're switching those gauze out. But once we finished with that cleansing, then we were able to get another fluorescence image, and you can see that it was much cleaner. And so what do we clean with? Well, this is a study done by Alicia Orapalo, who was in New York, the state of New York here in the US. And she did a study where she looked at 7 different wound cleansers that are commonly used. And I won't try to go through the list right now, but among them were betadine, acetic acid, hypochlorous acid, PHMB, but saline. And what you're looking at down below, of course, again, is fluorescence imaging. You see the wound before, you see the wound under fluorescence, and then you see it after. Well, the challenge is it was cleansed with normal saline. And while normal saline is inert and it's safe to use, it is not going to do anything in terms of the removing the bacteria because it simply doesn't have any kind of antiseptic qualities. So when we're looking at something that we know is laden with bacteria, we need to think further on what kind of cleanser we're going to use. So we want something that's going to have a high therapeutic index. It was in that chart that Keryln showed. Therapeutic index is really a ratio. It's looking at how cytotoxic is the cleanser that you're using to human cells, as well as how effective is it killing bacterial cells. And so what you want is a therapeutic index over 1, at least over 1. We want something that has either a neutral or more acidic pH so that we can try to normalize the pH in the wound. We don't have time to go through it, but do a little study on the impact that lowering pH can have on a wound bed. There are all kinds of bad things that happen when we have a very alkaline wound environment, including bacteria are going to be more proliferative. The proteases that can be damaging are going to be more active. Oxygen diffusion is not as well. There's a whole list of things. So we want to try to get that pH down to a more acidic level. And then something that could help us with our debridement. So one of the products that we use frequently in the United States is called WUWHS. It's a pure hypochlorous acid cleanser with 300 parts per million of the hypochlorous. And we started using this back in 2006, and this is, or 7. This is why I feel so comfortable using it on the wounds, because of the experience that I've had. But we used to have to pour it into a machine and generate our own, and then it was repackaged where we can have it over the counter. And we stock it in our clinic in the little tiny bottles, the little 4-ounce bottles. We will send that home with our patients, because that's just how firmly we believe that it's safe, it's effective. It has a therapeutic index of 6 and 8, depending on the kind of bacteria that you're looking at. And so we feel very safe giving it to our patients, because it checks all the boxes. It's safe, it's effective, it has an ideal pH, and it is recommended in pretty much any guideline on wound cleansing. But why hypochlorous acid? Because it's a naturally occurring antiseptic in our bodies. When you have your little neutrophils that come into the wound bed and they engulf bacteria, you may remember from learning this that there's something called the oxidative burst. And so when the neutrophil engulfs the bacteria, it releases hypochlorous acid internally, and that's what helps to kill the bacteria. So we know that the body finds it natural to use, and so it's something we feel comfortable using in the clinical setting. When we look at the effectiveness to kill, as you can see from this chart, quite busy, but you have between a 4 and 5 log reduction within 15 seconds. Now that sounds like, wow, am I going to sterilize my wound in 15 seconds? Well, no, that is the initial kill, but we also want to look at what it can do over time. And so that's on free-floating or planktonic bacteria. But when we look at bacteria that are growing in colonies, with a 10-minute soak, you can see we had a full 7 log reduction. So again, something that we can feel comfortable using and that we know is going to be effective. And so when it comes to the safety part of it, there's only 2 that are real in this whole list that are really safe as well as effective. Well, safe, not effective when it comes to saline. But again, it has the safety of saline, but the effectiveness of something that will clean. So I'm going to finish with this patient. This is a patient that we only changed one thing. That top picture on October 2nd, I walked into the clinic room and the nurse looked up at me who knows how I feel about wound cleansing. And she says, I can't even clean him. It hurts too bad. So we began to do a better job of using a topical lidocaine jelly. So it made it more tolerable. This was day I took care of him. I had some lidocaine on him for about 10 minutes. I used pure hypochlorous acid solution to clean the wound gently, and you can see how much cleaner it got. So in the top right, we taught him how to do it using a monofilament on a stick, and he began to cleanse it more effectively at home with hypochlorous acid. And then you can see his whole wound healing trajectory changed. So that's because we were using therapeutic wound cleansing. And so that is just the only thing we changed. We didn't change anything in his treatment plan. So Keryln mentioned the therapeutic wound cleansing. She mentioned integral debridement, and that comes from this Journal of Wound Care paper that was published in 2024, I believe. And they have just recently published an update to that, really focusing on the continuous integral debridement, where they recommend that we clean and then we debride the wound. And very, very important, and we bring this up in our therapeutic cleansing document, is that after you debride, you need to re-cleanse the wound, because you're going to stir up bacteria as you do that, and little remnants of tissue that you can't look. The wound will look clean, but you absolutely need to cleanse again after debridement so that you can get rid of any left behind debris. And then, of course, we would therapeutically dress the wound. So the integral debridement, that was part of the polling question, is the combined use of different but complementary methods for debridement. So you do a sharp debridement and you have a very short therapeutic window after that. And many times we see patients come back in a week later or so, and they have built up some material on the surface of their wound. And so we need some way to debride in between our clinic visits. And so it's a concept that just is very patient-centered, and we can adapt it to meet the patient's needs. So We have more than one approach to wound cleansing, wound debridement. And you can see on this chart, it's less invasive to more invasive. And so we need something that can complement each other and be able to carry the patient in between visit to visit. So there are barriers, though. Not every patient can have a sharp debridement. They may be in a site of service where there's not someone with that skill set. They don't have the tools to do so. And it may be that they either have a lot of pain when we try to do a sharp debridement, or they have maybe they're anticoagulated and we worry about bleeding. So we need something that will help us to continuously debride the wound, either in between our sharp debridement or as an alternative method. And so when we're looking at what we can use to do that, it's something that has to be effective and continuously removes that slough off the surface of the wound. It needs to be accessible, something that we can all use regardless of our site of care, and it must be comfortable for the patient and easy. It's not always a healthcare provider that's going to be doing these dressings, and so we have to have something that is or it may be a non-wound care specialized nurse that is doing the care. And so ErgoClean AG is a highly negatively charged dressing that is available with charged fibers. In the U.S., it falls under an alginate category, but it's really not used so much for absorption. It has these highly negatively charged fibers, and the pattern side that you can see that goes next to the wound is something called it's TLC-AG. It's lipidocolloid technology that actually forms a gel. And when it does, there is actually silver that's in this gel that's going to help us to continuously reduce the bacterial load there. So it creates this really friendly gel that is atraumatic when the patient removes the dressing, and it can stay in place for up to 7 days. So how do these charged fibers work? Well, it's like playing with magnets, which we all played with when we were children. We know that if you have 2 positive, they're going to repel. 2 negatives, they're going to repel. If they're neutral, they'll stand side by side, but we know that opposites attract. So a negative charge is going to be attracted to a positive charge. And so that is exactly how the highly negatively charged fibers in this dressing works, because the slough has a tendency to have a more positive charge. So because of the positively charged slough and the negatively charged dressing, they are attracted to each other, and it increases the capillarity or the pull that the dressing has onto the surface of the wound. There are other dressings that do have negative charges, but the negative charges are spread farther apart. And so when you look at ErgoClean AG, the negative charges are closer together, so it increases that attraction to the positively charged slough. Now, a question comes up frequently, well, I thought that bacteria had a negative charge, and so why would it pull bacteria out? Well, the bacteria are seated in that slough, and so as you clean out the wound and as you get the slough out of the wound, you're going to also be reducing that bacteria, removing that bacteria. Additionally, the silver is going to be helping to decrease that bacterial load. And so the strength of the charge is important. When we look at the negatively charged fiber dressing, it has in terms of the negative charge in millimoles, it's 4.13. And so the next closest is CMC dressing, which has 0.26. So the negatively charged fibers are 16 times more attractive to the positively charged slough. This picture, this video is really important to look at, because what you're seeing is the dressing coming off. And I carry a picture on my phone so that when I am instructing patients on how this works, and I also may send it to the home health agency or tell the patient to make sure their nurse knows that this is exactly what the mechanism of action is. This is not purulence. What you have to do is then look at the wound, get the wound clean, and then you'll see. So that is what happens to the slough on the surface of the wound. It interacts with the dressing and becomes this gel. But it could be scary for somebody looking at it and thinking that it's purulence. So this is actually the picture that I have on my phone, this one in the middle. This is one of the early patients that we trialed it on. And you can see that within 2 weeks, we were able to get that completely clean. So the one thing about Ergo is that they continue to do research to support and make us comfortable using the products. So this is actually a randomized controlled trial, and we don't find a lot of randomized controlled trials or RCTs in wound dressings. So this was an RCT that looked at 159 patients and compared it to another absorbent fiber dressing and found that there was a 50% increase at the end of 4 weeks, at the end of the study, the removal of the slough with the dressing. This was a huge observational study, and there's another one coming up. So we're looking at almost 4,000 patients that have been included in these studies. This is the largest ever conducted looking at a silver dressing. So this was over 2,200 patients, which 77 of them were under 18 years of age. And after only 2 weeks, 90% of the wounds treated demonstrated improvement in the healing process, reduced exudate, which makes sense. You reduce the slough, you reduce the bacteria, you're going to reduce the body's response to that. And so the exudate will naturally decrease. There was a 79% increase in the granulation tissue, and there were no issues with the dressing in terms of it sticking or causing any kind of pain or allergic reaction. Again, another 1,500 patients, and they found that as the necrotic tissue reduced in terms of the surface of the wound, the amount of granulation tissue increased. But they also found secondarily that their infection rates were lower, the odor was decreased, they did not have as much maceration. And then there was a reduction in spontaneous pain. Now, I had to look that up because that's not how I think of pain as spontaneous pain. But you'll think about your patients or also something that you might have had that hurts. The spontaneous pain is that sort of stab that people will get every once in a while on their wound, just a sudden increase in pain that may be wax and wanes. And so they found that spontaneous pain, as well as overall pain, was reduced by 60%. So how do these products work together? Well, the Ergo Clean AG is going to work regardless of what cleanser that you use. But because we know that the dressing has negative charges and the wound has a positive charge, the slough has a positive charge, if we can do a hypochlorous acid soak for even 10 minutes or so, it will enhance the positive charge to the slough and make the interaction between the dressing and the wound bed even greater. So I'd like to finish by sharing some cases just to give you a visual of how these products work. So this is a young man, 15 years old. So he really had no past medical history because he was only 15 years old. He was in an accident on an ATV or an all-terrain vehicle, and they had used Xeriform petrolatum gauze prior to him coming in, and he had injuries to his legs, but this was the worst one on the inside of his wrist. It was exquisitely painful. And so he was told that he would be doing his own dressings. And the reason is apparently he was not supposed to be on this ATV when he had the accident. So I made a deal with him. I taught him how to do his dressing. We did a wash soak for 10 or 15 minutes at whatever time he had. And then he used the Ergo Clean AG. And I asked him to send me pictures into text from his phone to show me how it was working. And so by day 6, now keep in mind, he was 15 years old, so he was going to close, but we needed to get that wound cleaner without causing him a lot of discomfort. And so you can see by day 11, he's pretty much closed. And by day 20, he was very close. So he continued to play baseball during this time. So he changed his dressing daily. He was simply adorable. And so I said, you know what? You should do a school project where you show wound healing and wound cleansing as one of your science projects. But I never heard from him again, so I don't think he did that. This was a patient the kind of patient that we all see now. Maybe you don't see this particular occupation, but this was when I was in New York, and he worked in a casino. And so casino workers stand on their feet. He was a dealer at a table, and they work on their feet all day. He worked very long hours, and they work for tips. So they get the betting chips slid to them when someone's leaving the table, and then they can cash them in. So he was on his feet all day long, usually worked 6 days a week, and he worked 12-hour shifts. So he had this very recalcitrant wound. We were using compression, but he had this very dense type of necrotic material that if you do sharp debridement, if you use a curette, you can almost hear it scraping. That's how dense it is and intact to the wound bed. And so we initiated the Ergo Clean AG here after we did a WUWHS soak. And what you see is in 7 days, it's caused that material to get sort of plumped up and more moist looking. And then you can see the trajectory. The day 28 was before and after cleansing. And by day 42, all of that necrotic material was out, and he did go on to close. And so, you know, again, demonstrating how is so attractive to that kind of tissue. This was a gentleman who had had open heart surgery. He had an arterial line that extravasated. And so what you're looking at is a necrotic wound that's right over the radial artery. And so he had this sclerosed vessel that you can see in the middle and in the far right picture. So we weren't going to do a lot of sharp debridement and rooting around in that wound with a sharp instrument. So we began the Ergo Clean AG on his very first visit. This is after 1 week. You can see how much cleaner it was. And by week 3, it was almost completely free of the material. And then, of course, he did go on to close easily then. This was a young lady who had a heating pad burn. It was in the winter. She had a heating pad burn to her breast. She was holding it close to her, sleeping it next to her chest. And so this was also exquisitely painful. And so we began the Ergo Clean AG here. This is before and after debridement and cleansing in our clinic, which you can see we did not make a big impact simply because it was so painful. So this is after just 1 week of the Ergo Clean AG. The one on the right-hand side is after 2 weeks of the Ergo Clean AG. And you can see this was prior to cleansing, but you can see the remarkable improvement in the wound as well as the wound healing that was taking place. And so in summary, thank you for, again, allowing me to chat with you today about the use of these products. Integral debridement just makes sense. It's something that we can have continuously going on so that we get the wound cleaner faster. And then the combination of the pure hypochlorous acid with the negatively charged fibers is really a multimodal approach to achieving a well-prepared wound bed. So with that, I think are we going to do another polling question, Hari?
Yep. Thank you. I think, Prof, can I have the polling question, please?
Yes,
Superbly
Prof.
done, Dot and Keryln. I think you covered. I think they should be very familiar with the whole thing now. Okay, let's have the polling question first. All right, what will you start doing in your practice? It's a general question, basically. Okay, while we wait for the responses, maybe we can open up questions. First thing is there any standard or ratio of antimicrobial in the wound cleansing lotion? Caroline, would you like to take this?
Sorry, Harry, it was just hard to hear you. What were you saying?
Is there any standard or ratio of antimicrobial in the wound cleansing lotion?
Is there any?
Standard or ratio of antimicrobial?
Oh, I see. Sorry, ratio. No, I
Mhm.
think the fact that the products are being commercialized, then they come, for instance, they come in a percentage that's considered less toxic. This is new age modern wound cleansing solutions. Some of the more traditional antiseptics, such as the hypochlorites and the earlier products, then we did have to dilute them down to a percentage. But if we're using new age dressings, new age solutions today, they come commercially prepared. So no.
Thank you. Dot, Dot, how can we constitute the pure hypochlorous solution? I think this is already answered, I think. Yep. And maybe the
Okay.
other thing,
I'm sorry, would you say that again, Hari?
I think the same thing from James here is how can we constitute the pure hypochlorous solution? I suppose the same thing as what Caroline has already answered.
Yeah, so when you're looking at pure hypochlorous acid in the commercial sense, it's 300 parts per million, so it's very effective. It has a very high therapeutic index. There are others that have hypochlorous acid, but a lot of them are mixed with sodium hypochlorite, and so that is going to raise the pH. I think another session that might be good to do, and you could get Terry Swanson to do this, is looking at pH. I think if people really paid attention to pH, they would see how beneficial it is to have a neutral or more acidic pH.
Yep, true. I agree. I think that was one of the older lectures they used to give, basically. I think Prof. Shukla and team used to talk about pH especially. I mean, even basically for the face and other places and all that. The other thing is from Nigeria, they've actually asked, how can ErgoClean be introduced to Nigeria as doctors in the hospital still use a lot of honey for debridement, despite the discomfort and pain to the patients?
Well, I think that would be a question for the folks from Ergo to yes, call in the hospital, and of course some of these things are not commercially available in all countries, and like I don't think WUWHS is available in Australia, for example. So it can be very country and location specific. But I think if, doing side by side, doing it as a quality improvement initiative to look at the pain, the level of discomfort, the effectiveness, and how rapidly the difference can be in terms of what they're currently doing is really the best approach on that, before you just say, oh, we want to change to something. When you see the difference, not only in the difference in how it works, but also the ability to clean up afterwards. Sometimes honey is a little more difficult. So again, that would be something to check with your Ergo folks to see how they could do a trial in their hospital.
That's good. And the other thing is, Caroline, I mean, you don't have WUWHS basically already in Australia and all that. So this actually is
no, it's just we're just waiting for it to be launched within the next few weeks, which will be exciting. So we have been following the literature and its use in other countries such as the United States. So we're yet to receive it, but it's going through our Therapeutic Goods Administration currently.
And I think from Africa, they actually want to know, because I think they don't have WUWHS over there yet. So they actually want to know, is there some other wound cleansing product suitable for low middle income countries, especially in Africa?
Look, I would just like to introduce them to a website that we have at Curtin University called WUWHS, WHAM Wounds. It's an evidence repository, and on that site, we have a lot of evidence statements and papers on what can be used in low resource countries. So whamwounds.com, WHAM Wounds.
Okay. So you have that basically, Zawadi, I think, please go to the website. I'll actually give you the whole thing.
Yes,
the other thing,
yes.
For painful wounds, do you recommend topical lidocaine before cleaning or debridement as part of a routine wound care? The process.
Yes, it depends on the patient and how we have, obviously if you have someone who has a neuropathy in their foot, many times we don't have to use anything. And it's amazing to me the differences in pain and even lower extremity ulcers. Some people have exquisitely high pain and some not. So part of that is the pain tolerance of the patient. But I feel very strongly about pain. Pain is what the patient says it is. And so we do commonly use lidocaine jelly, 2%, in order to reduce the discomfort because we're going to be therapeutically cleansing these wounds. It has been shared as a concern that lidocaine can be cytotoxic, but most of the time we're going to be debriding the wound anyway, so we don't worry so much about that. But we would always rather increase the patient's comfort, because if we hurt them, they're not going to trust us. They're not going to want to come back. And so we do everything we can to mitigate the pain that they may have associated with wound cleansing or wound debridement.
I agree also, basically, because the thing is, instead of us basically doing the quadrangle blocks and all that, which is going to cause pain because you have to inject in 4 areas, you see. at least basically using lidocaine, at least leaving it on for about 15 to half an hour, basically, it helps to actually cut down the pain. And these patients sometimes actually have quite bad pain, and the pain thresholds might also be low. So that's another
Yeah.
problem also. Now, Jeannie actually asked about the one that I always say I like, basically, clean the wound like you mean it. Should we interpret that as active removal of contaminants, slough, and discharge with adequate irrigation rather than just gentle wiping? And does your advice about showering apply only to clean, closed surgical wounds after 48 hours or also to open wounds like diabetic foot ulcers?
The evidence is primarily around the early studies in the 1980s looked at the surgical wound, which has been well approximated. But in many instances, cleaning chronic wounds is quite acceptable. And the studies that were done in the UK, again, in the 1980s also included chronic wounds. So yes, it is applicable. But you have to, again, as the consensus document stipulates, assess the individual, assess their wound for risk factors, and assess the environment in which they're going to be showered or washed.
Thank you.
We also concerned about runoff. We call it north to south contamination. So if it's on a lower extremity on a foot, like if somebody has a wound on the bottom of their foot, we don't want them walking into a shower. The floor is just not conducive to a good clean
Yes.
wound. So
Yes.
yeah, the location
yes.
also matters.
Yeah, I agree with that. So it's plantar aspect ulcers and all that. The other thing is any cleansing solutions which are contraindicated with the use of ErgoClean AG. Because I think this one stems from the previous thing where, when you use AG, you find that, you shouldn't use normal saline because silver basically combines with chloride and all these things. So in
Yeah.
terms of ErgoClean AG,
Yeah, there's
both of
no
you?
real contraindications. I mean, you're going to use, the most important thing is that you clean it. I would say that things like sodium hypochlorite, Dakin solution has a very high pH, like around 10. And so that might impact the positive charge of the slough. So I would use something either that is acidic or something neutral like saline. But it's not required for the ErgoClean to interact with the fibers. It just enhances it a little bit.
And the other thing is, I think we go back to what is the, the therapeutic index. I mean, if we reference basically to WUWHS and all that, how do you find in terms of the efficacy? So I think that was the latest one that we came out with the consensus, basically.
Keryln, do you want to answer or you want me to answer that?
I didn't quite hear it. I'm sorry again,
Okay.
Harry.
No problem. Caroline, basically, if you look at the therapeutic index, which Greg alluded
Oh,
to
yes.
and published paper. So when we're looking at basically WUWHS, especially now, how do you find basically the therapeutic index for WUWHS in terms of as a good cleanser? Because one of the questions in the poll was basically looking at a good efficacy and all that. We looked at pH and all these things. But I think we should allude to the fact that, therapeutic index is important. In terms of efficacy and also lesser side effects or even detrimental effects to the fibroblasts and everything else. So how do you look at
Well, you're
WUWHS
right. And it all comes down to good assessment, a comprehensive assessment, again, of the person, their wound, doesn't it? And you need to look at those factors that are putting that person at risk. And particularly those with diabetic foot wounds are a very complex population with a high risk foot. And so, we need to target our care to keep them infection free, or if they are infected, then we need to manage them with the best resources we have available. And I think prudent management of a foot wound is really critical, particularly if the bone is exposed or palpable. They have an 80% chance of osteomyelitis if the bone is exposed. And so, they absolutely demand the best antimicrobial management we can provide.
And further on therapeutic index, in the cleansing document, that's a new term, that's a new concept, and not all cleansers and antiseptics have determined or published their therapeutic index. So I would say stay tuned. I think we're going to see more interest in looking at the therapeutic index as well as which is really just looking at the cytotoxicity of the solution, and then as well as pH. So stay tuned. I think we're going to see more information coming out about that.
I hope so.
Yeah, that'll be good. I mean, within lots of what do you call that things. And now, if you look at hypochlorous itself, I'm sure you all have seen. Pash is one. Then now you're coming out. People have talked about Garidacin. They talk about basically Neutrophase. They talk about Nexudine from Italy. So many products basically. So at least with the therapy index, it's easier for us to actually choose, especially like in this case, because it's a whole group by itself. So. So I think we had a very good session. I hope the ergomedical team, which is here, would like to actually put up, number one, your website, your contact details and all that, because we have got quite a number of countries here. And even for Malaysia, I mean, I've got samples before this for the past few years. So it's also coming in, what do you call this, shortly, same as Australia. So I suppose what do you call this is good to actually give us the contacts. And the other thing is also the ErgoClean AG is already available basically in the Asian region. I think Malaysia, Singapore is already there. So it's good if you can put the contact details so our viewers can actually contact you for further info. And then with that, I would like to thank basically Caroline and Dot for taking time. I know one is in the morning and one is in the wee hours of the night. I mean, sorry, Perth is same hours as Malaysia, 8 o'clock at night, basically. But it's actually a very good thing to have the both of you basically present on the usage of cleansing substances and also the looking at pH, looking at the therapeutic index, and also with the case studies by Oakland AG and also WUWHS. And at the same time, thank you to what you call this Ergomedical for
Yes,
support
yes,
this education initiative.
yes,
And
indeed.
and I hope everybody has benefited from that. So with that, I think with the multitude of questions, we actually overshot time. Thank you to the what do you call this, the Endless 40 team for supporting this. So thank you very much and have a
Thank
good
you.
week. Take care. Bye.
Good night.
Night.
Thank you everyone for joining the webinar. Looking forward to have more series. Have a great day ahead.